Hi, as we're waiting for people to join today, I want to welcome you to our first in our series of oral health webinars that we hope to do monthly from now through June. For attendance purposes and tracking attendance, please make sure that you enter your full name in the chat, the manner in which you used it to register, especially if you've only put a first name and a last name initial or a phone number. We need your full name to be there. This session is being recorded. You can turn off your video if you're more comfortable. The recording and slides will be posted on our website probably in a week or two. We're going to hold our questions to the end, but feel free to enter them in chat at any time during the session. At the end of the session, you can unmute to ask a question or raise your hand, and we'll be happy to be monitoring those. If we've missed something that you've put in, please bring it to our attention. Again, raising your hand or opening or unmuting. And with that, I'd like to just present a couple of things about our speaker for today. We're extremely pleased to have Dr. Jill York with us today to talk about trauma-informed dental care. I think that's a topic we don't see very much in dentistry. And now I want to let you know that this presentation is supported by the Health Resources Service Administration, HRSA, so that we are able to present educational materials, programming resources to you through funding from them. The AIDS Education and Training Program have several national centers that you can visit for additional information. There's the Coordinating Resource Center that has a virtual library, has recordings and archives of previous webinars that have been presented across all ATCs. There's the Clinical Consultation Center, where you can have free peer-to-peer expert advice. The National HIV Curriculum that has updated trainings on HIV, 6 different modules with many lessons in those. And we have our own resource library here at the New England AIDS Education and Training Center. It's a compilation of materials, other public health topics. And last summer, or this past summer, we were pleased to be able to add a resource library page on oral health and HIV. And you can see the URL here, and we'll share that again later on. So Dr. York is an assistant dean for extramural clinics, the Hunterdon Endowed Chair in Dental Public Health, and a professor in the Department of Community Health at Rutgers, the State University of New Jersey School of Dental Medicine. Dr. York oversees the administration, operations, and clinical activities of Rutgers extramural clinics, and they receive Ryan White Part A, B, and F dental reimbursement program and community-based dental program partnership funding. You can find more information on these different HRSA parts if you go to hrsa.gov. Dr. York is a graduate of the University of Scranton and Georgetown University School of Dentistry, and we're so very pleased to welcome here today Dr. York. Jill, please.
Good afternoon. I will share my screen.
I will stop my video.
So I believe you can see that. So I would like to thank the New England AIDS Education Training Center for inviting me here today to talk about improving care for people with HIV in the dental practice using a trauma-informed approach. At the conclusion of this activity, the participants will be able to provide an overview of an approach that we at Rutgers School of Dental Medicine have used to integrate and implement trauma-informed care into our program. As Helene had stated, we are a part of community-based dental partnership funded by HRSA. In addition to that, you want to be able to provide concrete examples of strategies to create a more trauma-informed practice to improve the delivery of dental care. I must start with a little bit of a backstory on why I am an advocate for trauma-informed care. It was really December 6th, actually, 1970. I'm from northeastern Pennsylvania, and it was a very, very cold Sunday afternoon. And I was about ready to go to Sunday school. And my dad had got called into the office, and my mom had to bundle up two younger siblings of mine to go out into the cold. And my neighbor had stated, "Let me walk Jill to Sunday school." On that Sunday afternoon, a car slid on the ice and had hit both of us. My friend sustained minor injury. However, I was in a coma for 5 days following this incident. And what had transpired is I did, of course, recuperate, but it was a year-long battle of going to the doctors. And time again, you get good news, then you get bad news. My vision was blurred. I was suffering from headaches. But during this period, there was some good and there was some bad that came out of it. The good was that I had chosen to go into a healthcare field because I wanted to help others as someone had once helped me. But the bad was I had this, at the time I didn't know this, but I didn't want to go to get medical care. I always felt that every time I went, I was going to get negative results. So in my early years, my mom was in charge of that, and I continually went. But in my later years, I was in charge, and I really stood away from going to get care. A pediatrician friend of mine, and this is when I'm in my 40s, had recognized this, and he said, "Jill, you moved to Central Jersey. Who is your physician?" I said, "Oh, the gentleman, I'm still going to South Jersey." He said, a month later, "Jill, who is your physician?" I go to the doctor in South Jersey. He said, "Jill, you're not going to anybody." And what he did is he found me a doctor that really knew how to deal with individuals who had this type of trauma. And in addition to that, he made the appointment for me. And then every 6 months or a year, he'd follow up and make sure that I had went. So I do know the importance of trauma-informed care, and I do know that it does work. So that's what really led me to be an advocate for those individuals that maybe don't have a voice. So we'll begin with healthcare delivery in the United States, which really changed over the last few decades. And the role of the dentist has evolved. And it really began with this landmark report by the Institute of Medicine in the early 2000s that suggested that dental practitioners must work with other health professionals. And when we were talking about this, when we talk about this in discussion, it's particularly with complex health conditions. And we've seen that there has been great strides and the trend has proceeded since this time. In this report, they also recommended the provision of holistic patient care. And in dental education, we want to model excellence in clinical and communication skills. Communication is so key. And it's not only talking to your clients, but listening to your clients. And again, referring back to the pediatrician friend of mine, he was listening to me and he was actually hearing what I was saying. And we must do this with our patients. And then when you look at it from the American Dental Association, which represents most of the practicing dentists, they too have put this into their strategy. And what they said is we need to have collaboration amongst the professions, and we must have collaboration amongst the stakeholders. And this included the patient. So this was very, very important. When we look at the dental practice, we look at dentists and we say that dentists and other health professionals really can improve the experience of their clients by incorporating trauma-informed care. And a lot of times when we talk about this, we as dentists will say, "Oh, does that mean I have to ask these sensitive and difficult questions? My patients don't want me to ask that." And we've seen this with HIV. You know, a lot of times dentists don't want to ask, oh, are you HIV positive? How did you contract it? When did you contract it? We just sort of say, okay, you're HIV positive. That's fine. We're teaching our students that you need to understand the history of our patients. We need to incorporate what we know in the medical world with what's going on in the dental world. And it doesn't also mean that you have to become their social worker and psychologist. And in our practice, when we began asking these questions, the clients would say, well, you're not my social worker, you're not my psychologist. But we needed to explain to them why it's important that we know that. And dentists really do have a responsibility to work with all of our patients to make them feel comfortable, safe, and connected. And why do I say that? Especially with the HIV population, because up to 90% of clients that are HIV positive have had at least one severe traumatic experience throughout their life. And we need to understand that when we're dealing with this population. So Rutgers School of Dental Medicine is one of 12 community-based dental partnership programs whose major goals are to increase access to oral health care for clients with HIV in areas that remain underserved, and to increase the number of dental providers capable of managing the oral health care needs of people with HIV through service learning experiences. There are 5 evaluation tenets that we use in our program, and that's service delivery, education and training, involvement of our clients, partnerships, and in this year, when writing the new application, it's integration of oral health and primary care, which hasn't been in previous applications. And I said that this has been out for 20 years. So this is a new tenet by which HRSA is evaluating the programs. When we look at trauma-informed care, we know that there are the practices that must be employed. But let me start off by telling you at Rutgers, it's really an overarching premise or goal that is really guided by our philosophy in our interactions with each other. And it really amounts to doing small things in order to get great results. So we talk about service delivery. So we said 2 goals, service delivery and training the next generation of students. To give you a little bit of an idea of Rutgers School of Dental Medicine, for those of you who don't understand where we are. So Rutgers School of Dental Medicine is in Essex County, which is in the northern portion of the state. In 1989, we had realized at Rutgers, and I just began training in 1991 with Rutgers, but we had realized that people in the southern portion of the state could not really find access to care, affordable care, and those individuals that had government insurances couldn't find providers. So there currently are 3 community-based sites that are located in the southern portion of the state that are operated by Rutgers. And they are actually staffed by Rutgers faculty, Rutgers staff, and Rutgers students that are in their 4th year. There are 24 dental operatories in these sites, and we offer services Monday through Friday from 8:30 to 5, but then we have an on-call service that offers emergency and urgent care 24 hours a day, 7 days a week. And why do I say that in this opening introduction? Because clients need to understand that if they have an ailment, that they can call somebody. Because throughout their life, whenever they felt ill or they had dental pain, no one knows where to take them. They didn't have a home. And that's really what we want to establish is let our clients know that they have a dental home and that is part of trauma-informed care. It's the simple things that you can do within your practice that can make a difference. We also talked about education and training. So to give you an overview of what we do at Rutgers, all 4th year students are going to go out into the community to service clients. And this is really the underserved, underrepresented, and underinsured. We have 2 programs. In 1995, we started what is known as Code 1. And that is the full academic year where up from 9 to 11 students, they volunteer to go out into the community. And it requires an application. And then we have a selection process. And they start at the end of August or the beginning of September, and they complete their entire academic training. That includes their competencies, their summative, their formative type of evaluation is being done. And that's primarily done in Northfield and Somerdale. What we started in 2008 is what's known as Code 2. And that's a 2-week minimum where all fourth-year students go out into the community. They can go during summer break, and they go during the academic year. And the primary location for this project is in our Galloway location. Now, why is this important? Because findings from research have shown that training programs, such as this community-based dental partnership program, is very instrumental in increasing and enhancing the workforce capacity for vulnerable populations. I myself am a product of a HRSA program. I did it in geriatrics at UMDMJ School of Osteopathic Medicine. Once you get students to service, they either understand two things. One, this is something they want to do for the rest of their life, or two, this is something that they may not want to do, that this is not their calling, which is fine. We're just trying, if you can get one person to convert and realize that public health is so very important and that we need people to teach part-time or full-time, or to be in an FQHC, or to work, in State Department to be an advocate. It's very, very important. So workforce development is the second goal. When we talk about people with trauma, and we need to understand them. So what we did in our program, we had realized that people living with HIV are disproportionately burdened by trauma and the resultant negative consequences. And we realized that a lot of times it goes unrecognized and untreated, because the post-traumatic sequelae for this population is vast. And when we talk about it, we are actually looking at physical, sexual, and emotional abuse, family and community violence, natural disasters and war, the ongoing cumulative impact of poverty, racism, and oppression. And in my case, it could be just an accident that had occurred. It could be the death of a parent. These are all traumatic life experiences, big and small. And it affects individuals and groups across all genders, ages, socioeconomic status, geographic location, racial and ethnic identities, and sexual orientation. So you cannot look at someone and determine that they have undergone trauma. And we try to equate that to, you cannot look at somebody and identify that they're HIV positive. So you really need to do a history. You need to understand your clients when you're dealing with them. So at Rutgers, when we began our project, me being the leader of the program along with my team, we had said we really need to understand our baseline. So what we had done is, Rutgers being a very vast school, we partnered with the Edward J. Blaustein School of Planning and Public Policy. And this is a Center for Theory and Practice of Urban Planning and Public Policy Scholarship. And we did a pilot project at our school. And we wanted to get data in order so that we can understand the creation of the team. What our people were doing in our practice, how our patients were responding to this question of trauma. And what we did is we interviewed dental professionals and staff, and we wanted to get some type of feedback. We wanted to identify at the end of the project at the end of this whole program, which I'm doing today, is defining some best practices in our implementation of a trauma-informed approach. So some of the findings is that we did key informant interviews. And when I say we, it's not me, it's the Blaustein School. So we had an expert that was a faculty member, and we had an honors student who was interested in going into the profession of dentistry, who had done some background work in HIV. And so he had come up with a series of questions, and we have identified that dental practitioners unknowingly practice trauma-informed care. And this is before we started. When he asked questions, he said, that's trauma-informed care. We didn't really understand the basics. We understood the basics of it, but we didn't understand the academics of it. So why are we doing it? How are we going to do it? What is the outcome that we should expect? How will we evaluate our program? And we had found out that HIV status had little impact on the dental interventions. So we did not say someone is HIV, we think they're more susceptible to trauma as opposed to someone else. So what we had identified with that piece is that in our program, we were going to do a universal precaution. And everybody sort of understood that, because in dentistry, we talk about universal precaution when it comes to PPE. So what we were saying is trauma-informed care is going to be a universal precaution approach. And what our feedback came back as, elders and female patients are more willing to open up. So we have to be more cognizant when we're talking to our male clients, when we're talking to our younger clients. We have to explain things, maybe why it's important that you disclose this information to us. And what we found as really important is that our people were hungry for more information after this preliminary finding. So you really need, when you're doing trauma-informed care, as I always say, it's not a top-down approach, it's a bottom-up approach. They're the ones that are in the clinic. They're the ones that are interacting with our patients and clients. And that was very, very important for us. And we thought that that was a very, very great finding. So now that we have done some preliminary work, we knew where our baseline was. I want to give you an idea of what we did at Rutgers. And as Helene had stated, our program is one of the best, is part of the best practice compilation on the HIV Target Center. So who are we? RSDM, in partnership with the New Jersey Department of Health, they had received funding from the federal government to do trauma-informed care in primary care practices within New Jersey. And we were the only dental practice that was selected. And we partnered with Ciccatelli Associates. Ciccatelli Associates are the experts in trauma-informed care. They were going to be our educators. So we started with that. We were going to adopt this trauma-informed approach to care for people with HIV, but we did not really exclude it to all others. Once we learned the approach, we really extended it. But this particular project focused on people with HIV, and the outcomes were focused on that population. And we initiated it in January 2017. But I'm going to go through the process of implementation. You don't say today, oh, we're going to be trauma-informed tomorrow, and sort of just like, okay, that's it. It's sort of a process. There's an education, there's evaluation, and we started with our preliminary research. So our full implementation started in 2018. And as I had stated, I had given you the overview. It's in 3 community-based sites that are located in the southern region of the state. We had identified, being very strategic in this approach, that we were going to use the medical home model. And for those of you who don't know what that is, it's a team-based healthcare delivery model where the practitioner, and that could be our hygienist or our dentist, is going to lead this approach. And we are going to provide comprehensive and continuous care to our clients. And it didn't just mean oral health care. It means all type of care. We are going to try to help them remove barriers in other areas that would allow them to get access to this kind of care. And when we started this program, I want to say there was an aha moment. We always hear about aha moments, but there really was one. And it's when we were told that you don't ask the patient what is wrong with you, but what happened to you. Again, not what is wrong with you, what happened to you. So you all recall when a patient comes late for an appointment and you have to tell the patient, I'm sorry, we cannot see you today, and they're irate. And then you start thinking, oh, well, you're late. Instead, when the patient comes, we are taught to say, relax, what is wrong? What happened? And when you do that, you get a different reaction from your clients, from your patients, even from an employee who comes late to work. So this is when we had our aha moment. And we began to realize that when you look at this, now you can better understand why people miss their appointments, why they're late for their appointments, why they may have chronic and unexplainable type of pain, why they're not taking their medications. When you begin to ask, what happened to you? And this is really what was the premise from our program. So when we really realized that we were going to do this, is that we all came to this conclusion that we needed to understand the patient's entire life situation, past and present, in order to provide optimal care to our clients. So what did we do? Again, we're not the experts. We're deferring to others. And there are the 4 R's that have been identified. And the assumption is that when you do this, you will have a trauma-informed approach. So we really wanted to realize that trauma is widespread and that we needed to understand the potential paths for recovery. We needed to recognize the signs and symptoms of trauma so that we can better involve them within our system. We needed to fully integrate the knowledge about trauma into our policies, procedures, and practices. And then we needed to set up this continuation so that we can resist re-traumatization in the future. And this is really what led our practice. This is what we did in order to do that. So we began, again, you need to understand your organization before you can implement trauma-informed care. It's not a one-size-fits-all model. So we did an agency profile. And then again, we were working with Ciccatelli Associates, and we wanted to understand what type of services, what type of financing we had, what type of consumer engagement we had. So it really made you do an overall assessment of where you are. What is your staffing structure? And this was really taken into account by a 15-page questionnaire. So it was not something simple. And we had specific topic areas that we were looking at that were part of, I had stated earlier, service delivery, consumer involvement, education, primary and oral health care. So that would be like special project. So we were looking at our 5 tenets when we were doing this. And when we were doing this, we really realized what we needed to do. So when we started doing this, we said we really need leadership engagement. And what we did at Rutgers, we set up 3 pillars because we identified those as the most important in our practice. The first pillar was administration, and we needed to incorporate that into our policies and procedures. And that was organization. The second pillar was clinical integration. So taking what we learned and what we wanted to do and put it into our clinical program. And the third pillar was human resources. This is resources not only for our staff so that they can be trained, but resources for our clients. So if we identify that the client wasn't engaging with us because they didn't have a stable housing, we wanted to be able to find them stable housing. So this really was what we followed. Then we had the trauma-informed education and organizational readiness. So we had to be, organization had to be ready. We had to understand where we were. And then we had to educate them. And that's why we partnered with Ciccatelli Associates to understand what our agency, where we stood. And then we had to change the policies and procedures within our program, provide the training so that it can be part of our practice, and then implement it. Set performance targets, collect real-time data, redefine implementation plan as needed, and develop sustainability plan because we wanted this to continue within our program. So here right now is our organizational cultural assessment. And this was senior leadership who actually set this up. We developed work groups within our practice that were led by staff members. And how did we determine who was going to do that? Was volunteers, individuals that maybe had someone in their family that was traumatized, they themselves be traumatized, and they really wanted to get involved and understood this project. The assessment was completed, analysis was done by Ciccatelli Associates. We made a prioritization plan and we implemented our solutions. And again, this was a 15-page questionnaire. You can see that we did our current status, how was it ranked as a priority within our practice, and then the time frame that it would take for us to address that. So we were doing all of this ourselves. Then we did a physical environment assessment. And we did, again, the staff members went out, they did staff tours, the analysis of priority, time frame to address. Again, the evaluation tool that we utilized, again, talked about core values, which we'll speak of in a little bit. And one of them was safety for clients and staff. And there was the current status, the prioritization, and the time frame for completion. So really, what were we trying to accomplish during this cultural and physical assessment is integrate trauma-informed care into our culture, our environment, and our service delivery. So it was three-pronged. We wanted to emphasize education and awareness about trauma for faculty, staff, students, and clients. This was an all-inclusive program, all-inclusive. And we wanted to ultimately improve the client experience with health outcomes. And that was our ultimate goal. So I had said to you that we asked questions that were based upon key principles. And the key principles that we used are not our principles, but those that have been identified by others. So we were going to address safety, trustworthiness and transparency, peer support, collaboration and mutuality, empowerment, voice and choice, cultural, historical, and gender issues. Everything we did fell into one of these categories. So we'll begin our process so that you can see some of the things that happened within our practice. So we start off with physical and emotional safety. Clients need to feel safe when they come into your dental practices. And that's not only some type of physical safety, emotional safety, psychosocial safety. Healthcare organizations really need to set up a setting, internal and external, that the clients feel a sense of security. And the dental team can actually create this by actually addressing the concerns of the clients. And then what we do in our practice, we act as a liaison. So if we identify that the patient does not have some type of emotional safety because of some other issue, we will then get them connected to the medical care team, their case management, or other social services. But what we want to do is we want to create an environment that's non-shaming, non-blaming, and non-violent. And a lot of times we need to ensure privacy and confidentiality because clients really are afraid to come forth that with their HIV status. One of the ways in which we do this in our practice is we developed love seats in our waiting room instead of single chairs. And then we actually put up a signage in our clinic. So a lot of times it's nonverbal, communicating that it's a safe environment. And we put up during, in October, our entire practice turned purple. And we put up signage. And a lot of times our clients will feel more comfortable coming forward because they say, look, they're embracing this type of behavior. They're saying that we're support for you. So it helped our practice really immensely. And we do that every October. The second thing that we looked at was we wanted to create a practice where we have transparency with our clients, a sense of trustworthiness. More often than not, a patient or client does not come into your practice because they don't feel they can trust you. They don't feel that they can disclose their HIV status. They feel that you're going to begin to judge them. But if they feel that they can trust you with this, it's very, very important. And why is this important? Because more often than not, someone that loved them had hurt them. A lot of times when you're talking about physical abuse, emotional abuse, it's someone that is actually very close to them. And now you can understand why they don't feel comfortable, with a complete stranger. So we really need to do that. But one of the very important things is you want the client to feel involved in the process. So you want to disclose the policies and procedures to them. You want to maintain your professional boundaries. The third area is peer support. And just like myself, you're going to encounter people that have gone through similar things in our practice. So we try to embrace this type of peer support. And we want to have this personal level of knowledge with people who share similar situations. So if we ourselves have not shared that situation, we can refer you to a group that you can feel more comfortable discussing that. And why is this important? Because meaningful connections are so very important. You have to foster them within your practice. You want to develop a sense of understanding and empathy with your clients, and on issues that more often than not, they have felt that people, they're misunderstood. So this really is a very important part of our practice. We ourselves more often than not, do not offer the peer support, but we recognize that they need it. And then we immediately call their case managers or call their physician's office and we see how we can get them connected. And they really feel that that's an important part of their recovery process. And that's really what we're trying to do. We have collaboration and mutuality. The dentists and medical organizations really should view the clients as partners in the effort to develop their treatment plan. You don't overlook the client and not describe options that can be part of their treatment plan. You want to work with the medical team in providing care because you're not working in silos, and you want to work toward the same results and the results that the client has also developed. They develop their own goals. Where do they want to be? A goal may not be to have removable prostheses. So why would you do that? So we really need to give them back part of the decision-making process, and that usually you get greater buy-in from your clients. You want to have shared decision-making, and I think in dentistry, this is something that we have informed consent, and that's why we have that, is we want them to be involved in the process. And what I'm saying about this whole process, when we talk about collaboration, at Rutgers, we do not stand alone in this process. So you can see we partner with the government, we partner with support service groups, we partner with other schools within Rutgers. So we're partnering with the School of Nursing to bring doctorate in nursing nurse practitioner students into our clinic to develop a wellness passport, to tell them the importance of getting, pap smears, getting colonoscopies. We want to make sure that their overall wellness and health is doing well. We partner with the AIDS Education Training Center. We have to get the word out to other healthcare professionals. So this is an overview. Not only do we partner with those that refer clients to us, but it's the overall health of our clients that we're looking at. We talk about empowerment, voice, and choice, and this too is very, very important within our practice. Within our practice, we want to give our clients back their voice, and the dental team needs to empower the client. You have to make them understand that they are very important, that they are part of this process, and communication is very important. And that's why we stated in the early going that dental schools need to teach students how important communication is, the various types of communication, and the importance of the listening to your clients. You want to fight stigma regarding the disease and empower HIV people with a realization that we don't have to live in the past. We are going to be moving toward the future. We want to give them hope. And their oral health is a very, very important part of that process. Cultural and historic and gender issues. A program is not going to be trauma-informed if they do not recognize and eliminate bias. When we talk about bias, we talk about cultural stereotypes that exist. We're talking about race, ethnicity, sexual orientation. And in time, we have seen that sexual orientation delineations has changed, and your practice must be up to date on that. Your staff must be able to understand how to address people so as to not offend people. And it shows our clients that we're part of this process and we're all moving forward. And this is all part of your training, procedures, policies. It all goes hand in hand when you're dealing with that. And the key importance here is that you want to resist re-traumatization amongst your clients. This is an example of training. So you don't necessarily have to have a Chickatelli Associates that is receiving funding, but you can go online and Think Cultural Health has specifically a training for dental professionals, and it's broken down into 3 parts. Talks about linguistically and culturally and communication, and this is really a very valuable tool. So if you don't have the resources, a lot of times there are free areas that you can look at. So we want to say in our practice, what does trauma-informed care look like? And I just want to give you a brief overview of a client that came in that was sexually traumatized. And the dental staff is really concerned about scheduling appointments, our interactions with the client, the patient's missing appointments, they're coming late. But instead of asking the question, what is wrong with you? Why don't you view your oral health as important? Take a step back and then maybe realize that there may be triggers. Is there something we can do to make you feel more comfortable within our practice? Would you rather be seen by a man or a woman? And really, this is what is so very important, and it doesn't take much time. It's just really being cognizant of what your client is saying, either through their voice or their actions. A second example is a 50-year-old HIV client who sees their dentist and we realize they're not taking their medications. And a lot of times you want to yell at them, why are you not taking your medications? You can prolong your life, you're only hurting yourself. But instead of doing that, what you can do is take a step back and maybe identify what is really going on with this client, and then maybe give them the opportunity for a support group so they can work through this problem, because it's not something that's going to cure itself. And so we really work with our clients to get them to optimal health in all of the aspects. When we're looking at performance improvements, I had identified that we had broken it down into organizational assessment, environmental assessment, and clinical assessment. And these are just some of the outcomes that we have realized within our program. Policies and procedures and mechanisms exist to elicit the client and consumer to really maybe address them the way they want to be addressed. Employees are welcoming. Again, don't ask what is wrong with you, what happened to you. Our educational materials are placed throughout our practice. We put resources throughout our practice. Actually, in our waiting room, we had to put a resource about domestic violence. And instead of taking, looking at it and viewing it and writing down a number, they took the whole book. That was really our resource. So we had to recreate the book. People want to discreetly get information. They may not want to ask you. So you also have to be cognizant of that. We saw an increase in the number of unduplicated new clients that came into our practice. Clients of color came into our practice, and we educated the next generation of doctors that will be going out throughout the United States to practice. And hopefully they too will understand this importance of a trauma-informed approach to care. So I just want to show you a video that really sums up the message that I want you to take home today. So we know that trauma is a term that's used to describe a distressing event or events that may have a long-lasting harmful effect upon a person's health and well-being. And I had stated early on, and we had found this out with our preliminary research, that we were going to take a universal precautionary approach. That meaning that clients didn't have to show us signs or symptoms of being traumatized, but we were going to treat everyone with kindness, and we were going to try to create an environment that was very comfortable and provided some type of safety. So that's pretty much our message here at Rutgers. And I think it's so very important that we do this for the people that we serve. So I pretty much end with that, and I will stop sharing my screen. And I will open it up for any type of questions that you may have.
You can feel free to enter questions in the chat. Also, please feel free to unmute and ask any questions that you have in person. We'd love to hear from you. If I missed a question in the chat, please feel free to raise your hand, re-enter it. It's not always easy to follow the comments as they go by, and it's wonderful to see people really enjoying this. Okay, so we have a question here. Will training and trauma-informed care become part of standard dental education, dental hygiene, dental assisting?
So I can answer that question. And I too am a HRSA site visitor. And when we go out to do site visits, this is a very key component of our job, is to identify whether trauma-informed care is being taught to the staff and the primary care providers, as well as students that rotate through their program. In dental education, I teach the dentistry in the community course, and this is a core tenet that will be in our course. And I've also been asked to teach it in the postdoctoral programs, that being endodontics, periodontics, oral surgery. I will be teaching it to the residents as well. It's not going to be this extensive. It's not going to talk about the implementation plan, but it will be talking about the guiding principles of trauma-informed care and some of the things that you can do in your practice so that you can actually better help the clients receive access to care that might otherwise not because of trauma. So I do foresee that this is coming down the pike, just as interdisciplinary education is now one of the competencies that we have in dental education.
We have another question here. Did you experience any resistance from staff or students, and how did you deal with it?
So in our program, we've implemented it twofold, in the sense that we implemented it going, in the initial onset. But what we have done is we have used the AIDS Education Training Center out of Florida. It's Northern Florida. One of the individuals has developed a training tool that really gives you an overview of trauma-informed 101 for people with HIV. It's not, it's a really good training tool. So what we have done is, during our orientation process, for all individuals that enter our clinic, they have to view this training module. So that would be staff, providers, as well as students. And we try to answer any questions that they may have. So we do that the first day that they're there, they get this training, and we sort of explain it that this is our culture at Rutgers in our community-based sites. This is who we are. It's not something we do, it's who we are. And we are going to treat all people with kindness and care. And that we sort of explain that to our students is, we're doing the same thing they do at the dental school, but this is something that we want to do that makes it a little bit different. And that's why you're coming down here, to gain this experience. Because if we were going to do the same thing, we would keep you up in Newark. So right now we have not received any type of resistance. So I cannot speak on that. I think we've gotten buy-in. And a lot of times the importance of buy-in is including the staff as part of the process. Let them have a voice by which the way you're going to implement your program and things that you're going to do. As I said, our task force at the code sites are led by 3 staff members, one from each site. So it's not a leadership driven process. Yes, we're overseeing the process, but they are driving the program.
I'm not sure of an answer to this, but someone is wanting to know the best way to look up grant opportunities to implement a trauma-informed care program for any population.
So that's a really good question, because we've partnered with, we also at Rutgers have a Holocaust program, a Vet Smiles program, which trauma-informed care really targeted special populations and vulnerable populations. And what I say, the overarching premise, like in my course, it's not going to focus on HIV patients. I believe, this is my belief, the history of the individuals, the history of a Holocaust survivor, the history of an HIV patient, the history of a vet will give you some understanding of what they might be going through. But trauma-informed care it's really one set of principles and standards. It's how you use them to get to that audience. So what I would answer your question is, there are funding opportunities that we're finding here at Rutgers through foundations. And so you look at the mission of the foundation. If the mission of the foundation, so the Jewish Federation, their mission is Holocaust survivors. We were able to get funding from them to implement a trauma-informed program so that their patients can better access care. We're looking at Delta Dental for another program that we have here. They're very big advocates on, a different Vet Smiles. That's our program that we're using that for. So you can look at foundations, federations, the federal government. If you're already receiving funding to service a special population, include that in part of your training piece if your program has access to care and training. So yes, I do believe that if you're creative, you can actually find a way to fund getting the support that you need to implement this, because I believe that others view this so very important. And with the outcomes coming back, that you have better client engagement, treatment adherence, you have wellness of your faculty and staff, I think it is making a difference.
Jill, there's someone who had signed on late and was wondering if she saw a slide that HIV is not a factor for trauma related to dental care, or did she misinterpret that?
Yeah, so basically what we said is that our students and our faculty and our staff do not treat people differently that have HIV. Like, we don't say, oh, only people with it. We're treating people with HIV differently about their trauma. What we view it as, everybody could potentially have trauma, and we need to address everyone in a different way, meaning once we identify it. So no, I did not say that people with HIV are 90, as I stated, 90% greater chance of having a severe traumatic experience throughout their lifetime. So what I meant in that slide, if it was not clear, again, I'll state that, is that our staff did not treat people with HIV differently as it referred to trauma-informed approach.
Thank you. I think that made a good understanding there.
Thank you for bringing that up.
We have time for more questions. Anything that you'd want to ask, or maybe transitioning into private practice or other waiting room experience? You're getting a lot of, good feedback. People have really enjoyed this. So let's see if we have a few more questions before we have to sign off here, please.
If anybody has any specific questions, or your program is implementing it and you want to talk, a little bit more, I'd be happy to talk to you. As I stated early on, this is something that I truly believe makes a difference, and I've seen it make a difference. So, we talk here at the school, it's the little things that you do. It's the, what you say to your clients, how you say it to your clients, that makes them feel comfortable. We've had people in our practice that had a history of cancer, and they had a sialolith, they had a salivary stone, and they were so afraid to come into the practice because they just assumed it was cancer. So you really need to explain to your clients that, we can help you, and not everything is going to be negative. It can be a positive outcome, even if your diagnosis, it seems grim at the beginning. So we try to do that for everything and everyone. So it's really the way you approach it. It's an overarching philosophy, as I had stated. It's what guides you. And if people really understand the principles of what trauma-informed care is, they sometimes will ask themselves, like, am I really explaining this to the client the right way? We've also included this into our pre and post test. So all of our students, we want to get baseline data on their knowledge, attitudes, and behaviors for people with HIV. And we've included trauma-informed care into their post test. And 100% of our students last year believe that you really need to understand the entire life history of a client. And they believe that these principles are something that will be incorporated into their practice after graduation. I really want to thank everyone for taking time out of their busy schedule to attend this seminar. It shows me that you all believe that it is something that is very important, which is important to me and to the people that we serve. And again, I want to thank the New England AIDS Education Training Center for inviting me here today.
And we want to thank you for a really informative presentation that I think contributes to our knowledge and culture, and something that we don't often think about. You know, I know how sometimes you hear somebody describe themselves as a white knuckle. Why are they white knuckle? Why does their blood pressure go up and when they see a white coat? So I think this information is just so useful. And every time I hear your presentations, I feel like I walk away learning so much more. And everyone is thanking you. You're getting excellent presentation, important topic. Was going to ask about hesitancy, but it was already asked. So instead, thanking you very much. Important work, enjoyed it. Access to the slides. The
Yes.
webinar will be posted on the New England AIDS Education Training Center website. More great presentation. I think you really bridged a gap here in dental education and dental clinical service delivery. Couple more minutes if there's any more questions, please. And I did want to make sure that you saw in the chat our part 2 in this series of oral health webinars through the New England AIDS Education Training Center will be January 11th and presented by Dr. David Resnick, and that is on emerging viral diseases, implications for people with HIV and people without HIV. So it's been shared a couple of times in the chat for you.
Okay, we have another question, Helene.
Oh,
How
we have
did
a
the
question.
program incorporate behavioral health into the program, like external referrals to outside providers? So that was a little bit of a challenge, and so that's something we're working on. So initially, when the program was launched, they thought that we were going to be asking a PTSD questionnaire within our practice, and we got a lot of pushback from our clients. They felt no reason to be telling you. And the other thing that we had uncovered is if you find out someone was abused, what does it matter how long ago it happened? You know, to what extent so we found out that we really didn't need to know that type of information. And what we're working on right now is what type of questions are going to become standardized within our practice. But what we have done to bridge this gap is, again, we're an academic institution and we are partnering with the Rutgers School of Nursing in Camden, where we're going to have Wellness Wednesdays. We're going to have a day, several days, where the nursing students come in with faculty, and we will be offering counseling services within our clinic. We believe a one-stop shop, and a lot of times with referrals, to close the loop, it's very difficult to find out if they went and what were the reasons why they didn't go. It may not be that they don't want to go, they don't have childcare, they don't have, and then there's a whole number of other issues that we had to deal with. So the way we're dealing with it, we're going to be bringing in the behavioral health experts into our clinic and then offering that service within our clinic at that site, which is pretty much an ideal circumstance. But we're also going to be incorporating that with wellness. So we will be doing cholesterol screenings, blood pressure. We'll be taking blood pressure, BMI. So this is a very large program that we're going to be focusing in on wellness within our program, and not only helping those that have maybe experienced trauma, but others that have not. So that's really the way we're going to be dealing with it. But that's a topic I would like to maybe discuss with you further on how dentists really can do this and do it well. Because I do believe that's one of our biggest challenges that when we started out this program.
Any last questions before? So Dr. York, thank you so very, very much for taking your time to share this incredible information with us. And again, a great contribution to the delivery of oral health care services, the safe delivery, the confidential and quality delivery. We really appreciate it. And thank you all for attending, and we hope to see you January 11th for our next conversation in our oral health series.